Good to see all of you guys today. Most of you I know, some are new faces. So Waldenstrom and dermatology is a pretty big topic. Surprisingly, it's super rare, but there's a lot of things that go along with either disease-related or treatment-related. Just a quick overview of WM. I know most of you know somebody or have it yourselves, but just a little bit of 101. It is a disease of the IgM protein where this is overproduced in Waldenstroms. This is tested through blood work and also is a lymphoplasmacytic lymphoma. So we test that also in the bone marrow. It infiltrates many organs, including the skin. Because of the size of the IgM molecule, which is quite large, it can cause all kinds of problems. Neuropathy, skin disorders, fatigue because of the blood counts being decreased and unable to be produced in the bone marrow. So several things that go along with WM. There's the 3 classifications of it. We've got IgM MGUS going up to smoldering, and then those who become symptomatic. And then various treatments we'll just briefly go over. We're not going to go over a whole lot of the treatment stuff for me. Dr. Forsberg will talk some about the novel treatments coming up. And then because of the treatments we put you guys on, there can be skin, hair, and nail changes. So this is just a picture talking about the large IgM molecule. These are the proteins that are produced in our immune system. IgA here is quite big, and this is why it infiltrates organs and skin and can cause problems. And if I'm going too fast, we have a ton of information, so just raise your hand and say, slow down or back up or whatever. This is very informal, so let me know. So IgM levels are monitored in the blood, and some patients can have very few symptoms with a very high level, and other patients can have a ton of symptoms with a very low level. So as you know, we don't treat the number, we treat the symptoms. And that's why we're monitoring you guys frequently and your labs as well. So here is a long list of dermatologic conditions related to WM. On the left-hand side, you can see the treatment-related, and we'll discuss all of these a little more specifically coming up in the slides. And then the disease-related, this is really only about 5% of people who get disease-related dermatologic or skin reactions because of the disease itself. So you can see there a lot of big names that we'll write down here in the future slides. Oh, and if anybody would log into WebEx, I just want to make sure that, because I can't really tell from here, that people online can hear me, or I just want to make sure that they're not being excluded. So again, only about 5%. The neoplastic causes are what are from the disease or either the IgM molecule or the lymphoplasmacytic cells themselves. And then the non-neoplastic would be from complications of the IgM paraprotein and also the treatment related. So rarely do the lymphoplasmacytic cells infiltrate the skin. Here are some pictures before and after of different things or way that disease-related rashes can look. They're called cutaneous macroglobulinosis or bullous disease, and you can see where the skin kind of erupts, can become quite painful. This rash, it's usually, for most people, really kind of nondescript. It looks a lot like this picture on the left, and is generally not bothersome. Sometimes it can become pretty itchy. And then as we treat WM, this fades out, does resolve. Hyperviscosity is a symptom or is caused from the blood being thick. So this can lead to different dermatologic complications in and of itself. So there can be bleeding, swelling, which then can cause the skin to weep or blister. Bleeding risk with brushing, flossing, blowing your nose, nosebleeds. So this can cause skin issues related to the disease. Also, people who have cryoglobulinemia, which is when the blood proteins clump or precipitate when the blood is cold. And so this is tested through a blood sample, generally on diagnosis with a thorough exam, but can be if it doesn't get it doesn't get tested when you're diagnosed. This can be tested through a blood sample at any time if you're having symptoms. And then purpura, which looks like these big dark bruises. So these are generally pretty benign, but can be caused from vessel occlusion, which the IgM protein, so they can be painful, and also are related to hyperviscosity. Raynaud's phenomenon, this can be related to WM or not. A lot of people out in the world have this and don't have WM. This also occurs from lack of blood flow. So when you're out in the cold, whether it's getting into the freezer or just being in Colorado in the winter, you can get where your digits, your feet, your hands can turn anywhere from white to really dark purple with decreased blood flow. This can be pretty painful. So a lot of times people, even just to reach into their freezer if it's severe, have to wear gloves. So really the big thing is keeping the skin warm, the hands and feet warm to decrease pain. They oftentimes, don't break out with sores from that because of decreased blood flow, but it can be painful, and sometimes they can have a little bit of skin breakdown, but that's not terribly common, at least from what I've seen. And then when the skin warms up, the blood flow returns and the hands come back to normal, but it can be pretty bothersome. So the cryoglobulinemia, which we talked about a couple minutes ago, can have some related conditions. So this levator reticularis is this web-like rash that you see there. It's between the lower flowing blood vessels and the larger blood vessels, and it occurs usually in the area of the lower blood flow. And then people can get vasculitis, which is inflammation or narrowing or blockage of the blood vessels, and that can be painful and cause skin breakdown, poor wound feeling. The vessels can rupture, so that can be more of an urgent situation that we would need to treat. Usually, when these occur, if these are presenting symptoms and you're at an outside facility and trying to figure out what's going on, there's a lot of things that can cause vasculitis outside of WM. So treating the underlying cause is what needs to happen to fix this. Schnitzler's syndrome is often a diagnosis of exclusion. So this is something that, you've been tested for many, many things and everything else has been ruled out. And then I remember reading about that in medical school, and test for it, and there you are. So it is associated with the IgM protein. It is more common with our IgM kappa folks versus our IgM lambda WMers. And it's usually a constellation of symptoms, so it's not just a rash. There's often fever, bone pain, more swollen lymph nodes in a certain area, neuropathy. So there is other pains that generally go along with this. It is rare. It is underdiagnosed because it is a diagnosis of exclusion. And again, treating the underlying cause, so treating WM is what fixes this. There's another condition called Sweets syndrome, named after I don't know if he was a doctor, but Robert Douglas Sweet. Again, This is a diagnosis of clinical symptoms, pathological symptoms, as well as laboratory findings. So these people can have fever, tender red, skin lesions. The labs show an increase in neutrophils, which is part of the white blood cell, and really needs a skin biopsy to have this done, which is something we do in the office all the time. Doesn't need stitches, and you just do a punch, and that's how we can diagnose this. It can be people can have it without having a cancer diagnosis, but generally we see it with somebody who has some type of malignancy. Doesn't have to be just WM. We do see it in other patients that we treat as well with other blood cancers. The treatment generally is a topical steroid, sometimes oral steroids, and some people need injections into the skin lesions to get those treated if it's not resolving with treatment of the underlying cause. And that would be at a dermatology office or somewhere else. We don't inject into the lesions. Another type of rash is the neutrophilic hidradenitis. Again, white blood cell caused. This can erupt when chemotherapy when you're as a treatment related side effect. When chemotherapy stops, the rash does improve. It does affect the sweat glands, which could be anywhere in the body. And some people can have fevers with this as well, so it can appear to be kind of an infectious rash. Definitively diagnosed again by a skin biopsy to see, is this a viral rash? Is this something, contact dermatitis? So many of these things mimic each other that it's really hard to diagnose. Usually this one is self-limiting, so it kind of runs its course, and then if you don't treat it, it will dissipate. But oftentimes being treated with steroids kind of cautiously under the care of a physician would help to expedite the healing. And one antibiotic that we use for many things here called dapsone is what ends up being one of the things to treat this, which is an oral antibiotic. So when we do manage your WM, there can be side effects from the treatment, which many of you experiencing now or have been experiencing in the past. So we'll discuss all of these coming up, which are treatment related, not necessarily from the disease itself. There's in other support groups, we've talked about skin conditions related to amyloidosis, which WM patients can have. It's a secondary issue, so in another plasma cell disorder. So there may be secondary causes in addition to WM that can cause some skin disorders. So when we're treating most people at some point with ibrutinib or zanubrutinib, the BTK inhibitors, we have intended treatment related to, we want to treat the WM by blocking BTK, but there's also kind of off-target side effects that happen. So you get bleeding, bruising, rash, skin and nail changes. So nails can become pretty brittle. You get skin cracking. You can get kind of the curls in your hair, high blood pressure, AFib. So these are unintended side effects, but a side effect of the drug itself. Ibrutinib is certainly more of the risk for this. Zanubrutinib, which is our second generation BTK inhibitor, does not quite have, yes.
What percent of patients on those drugs get these effects or these side effects? Are they common? Are they not so common?
The skin changes are pretty common.
Okay.
Yeah, I'd say most people will have some, whether it's just cracking of the nails or kind of dry, brittle nails, that is really common. Okay. AFib, we give it to so many people. It's not a common side effect, and zanubrutinib certainly is less of that complication than ibrutinib. Bleeding, bruising, absolutely. It's like an aspirin, so we have to hold it for procedures. If you're a WM person who flares when we hold one of the drugs, so you get fever, aches, you feel like you have the flu, or the IgM just shoots way up with any drug holding, then we may opt to say, you know what, we can't hold the drug. We just know that there's a risk of bleeding with the procedure, and we just have to take that risk. Or give you steroids if we do absolutely have to hold it. And bleeding, bruising, I don't know, Peter, do you think pretty equal with zanavirtinib or ibrutinib, or more with the
A little bit lower rates with Zeta-Citnib.
Okay. Yeah. Okay. And blood pressure, we do have to keep an eye on that. We don't stop the drug. I mean, unless we have to, if we can't get it controlled. A lot of this stuff, AFib, high blood pressure, we treat the side effect and keep going if we can.
Mm-hmm.
And oftentimes we have a cardiologist helping to manage some of that if they need to. Risk for skin infections just because of the skin breakdown. So you're more at risk for Staph aureus, which oftentimes you hear called cellulitis. That has to be treated with antibiotics. It's not something you say, oh, I've got this red streaking spot on my arm from skin breakdown, and then it's like spreading up your arm. That's something that's urgent and needs to be on antibiotics. Folliculitis is kind of just a more minor staph infection of the hair follicles. Doesn't necessarily have to be treated with antibiotics, but you can, or systemic antibiotics, you can do a topical antibiotic, but something that you'll want somebody to kind of monitor. Paniculitis is inflammation of the subcutaneous or the adipose tissue, and that may require, if it's kind of recurrent and difficult to manage, may require steroids or lowering the dose of ibrutinib or zanavirtinib if it's something that we just can't quite get hold of. And also when we're lowering your immune system and with WM, you have a more risk of infection just because of the disease itself. So you do need to just kind of monitor risk of infection in general. Risk for herpes, either herpes simplex or herpes zoster, which is shingles, ulcers in the mouth. We don't necessarily see this, or I haven't, with a normal immune system where the white blood cells are normal, but if these medications do drop your blood count and the neutrophils are neutropenic, we do see people come in with this ulcers like big kicker sores, and about, as you can see here, and that's just what it looks like and so painful. That's generally a side effect of the white blood cells being low. Trying to get the white blood cells up, whether that's an injection of Granix or something to help boost the white blood cells, decreasing the dose of zanavirtinib or ibrutinib, holding it if we can, treating with steroids would be things that we could try. Shingles is, that's a different story. Getting the shingles shot is really, for the vaccine, is really, really highly recommended. We do oftentimes, even if you've had the shingles shot, keep people on Valtrex or acyclovir despite having the vaccine.
How often should you get the shingles vaccine?
It's just like it's a series of 2 and then you're done, as far as we know.
It's not an annual.
No, yeah. And then we would, if you did get shingles, that's something we would want to treat with pretty high dose acyclovir or Valtrex. It can be painful. I mean, I haven't had it, but people who do have shingles oftentimes need to be treated with gabapentin or Lyrica to help with that neuralgia that goes along with it. And it can be, the quality of life can be affected for sure. Here's just a list of some things that a lot of our patients have tried: mane and tail lotion, working hands, not using anything with fragrance or alcohol in it. That'll dry the skin out more. May need steroids, preventing infections. So just various topical things that are just over the counter and easy to get a hold of. Infection, we talked about, always needs an antibiotic. Rash may or may not be bothersome, so sometimes that doesn't get treated. And here's pretty typical pictures of what we see, the skin and nail changes. Those can be painful. I mean, if your nails are cracking like that, catching, I mean, that hurts. So a lot of people, men even, wear clear nail polish on their nails to protect that, wearing anything to cover it if it's catching on your hair. And then the rash, again, this usually is pretty benign and just looks bad, but isn't bothersome. I'm going to kind of skip over this. There is a risk of psoriasis with people who've had Rituxan for treatment. We don't see it a whole lot. We can discuss that on the side later because it's not something we often see. And then, always discussing these with your provider. It may or may not be related to what we're treating you for or the disease itself, but mentioning these things because it may be. And again, it's rare, so we like to keep an eye on this stuff and get skin biopsies if we need to. And if you're having, fever, skin rash, these kinds of things, we do need, we want to know about that because it can be a more serious side effect of things. So we always want to help minimize any complications we can. All right. And I am going to turn this over to Dr. Forsberg. Oh, and then there was a mention about skin cancer. Zanubrutinib can have a higher risk of skin cancer, so getting a regular dermatologic screening for that, like at least every year, is a must.
Perfect. Well, great. Yeah. Okay, I'll jump right in.
Dr. Peter for
And it's great that Kate is interested in dermatology. I remember I did a dermatology rotation during my 4th year of med school because I was like, I want to see a lot of rashes. It's just sort of learn about this. It was probably the thing I did worse at in all of us. So, well, there's like a classic joke, with dermatologists, there's 1,000 rashes and 3 creams. But it was interesting hearing the talk just because, some of those things that Kate highlighted are kind of rare. And I am excited about, how, sometimes we patients come to us and they look around and say, oh, I have these things that were there for so long. How did it take so long to find a WM? And I am hopeful that some of these AI type tools that are making their way into primary care clinics and other places might help people to sort of get that pattern recognition that sometimes you need to see somebody who sees a gajillion WM patients. So hopefully we get patients from weird rash to the WM diagnosis faster in the future, because that is stuff that some of those are fairly rare complications of IgMs or other things. But if you know what to look for, it can lead you to that sort of, that click in. Well, glad to talk with you guys. Admittedly, since last time we did this, there have not been any big changes in our practice. In WM, sometimes our changes happen gradually. So there will be some retreads of slides, but, I think Bill thought it would be good to sort of go through some of this stuff again, just because, it can a little bit of repetition can help us make sure we know exactly what we're working on, because we do know a lot of the drugs that are, in development, and we do have exciting stuff in the clinic that is in development. Just take time to go from initial proof of concept to accessible option for us. We didn't have any big WM updates. Every year we have big meetings in the summer and big meetings in the winter. The biggest one every year, outside of our international Waldenstrom's, working group meeting, which will happen next year. We don't have one this year. We had our last one in Prague last year. We have one coming up in Palm Springs in 2026. So we'll be going to that. But we probably get the most data every year at our American Society of Hematology meeting. That's in December. This year, we always have what's called ASCO and EHA. Those are our big summer meetings. Didn't have a lot of WM updates this year, so not a lot of hot off the presses stuff from those meetings. But we'll be looking out for what's coming at ASH. And, one of the things, Kate mentioned, and one of the questions that came up, I guess, it's been, more complicated than ever to sort of make sure we're getting the right information and good digestible information for what to do with certain things like vaccines. And so one question was, what should our approach be for vaccines with patients with WM? And, the truth is, and Kate could sort of, give her thoughts too, I tend to lean into, there are American Society of Clinical Oncology guidelines for how to manage vaccines for patients with cancers. And they give relatively broad. They're not all disease specific. There aren't really, broadly robust WM specific guidelines. One kind of user tip that I would sort of recommend if you're ever wondering about something, WM's a little rarer than other cancers. So if you're looking for comparable diseases, the one I tend to think of that's most similar is CLL. So if you're looking up guidelines and you don't find something for WM, you could always see is there stuff for CLL, because that's where we also use drugs like BTK inhibitors and venetoclax and BCL2 inhibitors, and patients might be living with sort of some chronic immune suppression for years and years. So looking at that for guidelines, but essentially, we're always going to recommend your annual flu vaccine. If you're over 60, for now, that's still the guidance for RSV. COVID, I know that's one of the more hot button topics, but we tend to be sort of leaning towards just following CDC guidance, and there'll probably be a recommendation towards annual updated vaccinations along kind of like the flu shots. But I don't know what's going to be coming out of the CDC. It's obviously a complicated landscape for government guidance with stuff right now. The question about the Shingrix shot or the recombinant zoster vaccine, 2 shots. Sometimes if we need to compress them because we have a patient who's about to start chemotherapy, if you're a smoldering or asymptomatic WM and you're moving towards therapy but haven't had Shingrix shots, we may do them even closer together than the 2 to 6 months between shots. It is something where we go past the age-based recommendations. So even our younger patients should get Shingrix shots and pneumonia vaccines. Beyond that, there are obviously always, what about me specific questions that come up in WM because we create unique circumstances. So questions like, what should I do if I'm on a BTK inhibitor? What if I have hypogammaglobulinemia? What if I'm getting IVIG? What if I just finished my BR 3 weeks ago? These are all kind of specific scenarios. And, truthfully, we lean into a lot of those, sort of seasonal programs we sort of stick with. Even if you're immune compromised, we still do our shots. We may think about timing, sort of seasonal vaccines or Shingrix or other things around your IVIG or sort of, waiting for a while after finishing chemotherapy. Certainly the one that's often been on folks' minds recently is what about measles and how much extra risk am I at for things? We do still have restrictions on who can get live attenuated vaccine boosters. So that is an area where there's less evidence than some other things. So a lot of times we may adapt our recommendations to situations. So if all of a sudden there's a big outbreak, we may start to get a little bit more progressive in terms of how we approach some of this stuff. But those are things we do still think there are circumstances like being on a chronic BTK inhibitor where we wouldn't recommend live attenuated vaccines. And if you just recently had chemotherapy, you may need to wait for a period of time before considering that. So some specific circumstances that are not as evidence-based and where we sometimes have to just make best decisions on the fly a little bit. So this year we did get some publications from our IWWM meeting, our workshop last year. None of these really were changing what we've been doing for the most part, but we always, the meetings are great because then you get a bunch of good minds together. They can put something down on paper, and that way everybody, wherever they may be and however many WM patients they may see, can have good guidance for how to approach stuff. So we got recommendations on what to do with Big Neal syndrome, which is CNS WM, which basically recommended zanubrutinib as the sort of the go-to. BTK inhibitors get into the nervous system better, so zanubrutinib is now that recommendation. High risk WM remains a work in progress. Defining high risk WM and coming up with specific guidelines. Basically, the recommendation was we're going to keep working on it. We're going to keep trying to drill down on what that is and hopefully design trials specifically towards higher risk WM patients in the future. What to do with sometimes people have WM without the IgM. There are some people who have the same thing in the bone marrow, but instead it makes IgG or less proteins. And the consensus was treat those like regular WM. They're going to respond similarly to other therapies. And then what to do with transformed WM. This is something that Dr. Mattis ran through at our last meeting. But basically, we have an algorithm. So occasionally, WM changes its stripes. Instead of being an indolent lymphoma, people can have what we call transformation. And that's where an area or multiple areas become what we call a large B cell or a much more aggressive lymphoma. And basically with that, we need to treat it pretty aggressively. We need to move into intensive chemotherapy. We need to treat for the possibility it can go into the central nervous system. We need to think about a transplant if things go well, or if not, we need to move towards a T-cell based therapy like CAR T. And we were actually sharing some of our data for some of this stuff with international colleagues, so we can get more data around CAR T and some other things in this, just because it is a rare enough situation where we need to all be collaborative to make sure we're getting good evidence.
What's the frequency of the transformation from WM to large B cell?
Yeah, it's a few percent. It's a single-digit percent event. Whether or not that's changed a little bit in the modern era, as we just have more patients living with WM for longer, so that's a good thing. But it is something that probably is a little bit unpredictable. It can happen, a year after people are diagnosed. It can happen 10 years after people are diagnosed. So we see more total events, but the frequency of it seems pretty similar. So less than 5%, but it happens from time to time. Yeah. So, update on our myeloma toolbox. What do we have up our sleeve if you are diagnosed with WM now, or if you were diagnosed a few years ago outside of clinical trials? Monoclonal antibodies, rituximab and obinutuzumab are our main ones. We use those sometimes alone in certain situations, but we often combine them. And when we combine them, we can combine them with a variety of different things. Chemotherapies. There's lots of folks in here who probably had either, had bendamustine or cyclophosphamide or both. And usually those, we call that chemoimmunotherapy. We sometimes combine them with what are called proteasome inhibitors, which are a targeted therapy. They have a role in WM. There's bortezomib or Velcade and carfilzomib or Kyprolis. Again, those are usually combinations that are for fixed periods of time. Those have a little bit more steroids built into the combinations. Then we have BTK inhibitors, which are our main approved therapies. The things that are specifically approved for WM are zanubrutinib and ibrutinib. I'll talk about pirtobrutinib again this time. I talked about it last time, but it's a newer BTK inhibitor that works a little differently that we can get access to, but it's off-label. It's not approved for WM right now. Mm-hmm. And then venetoclax, which is another approved drug, not approved for WM, but we can get access to it in WM because of the data we have, and it's approved for other diseases. So, we maybe we sometimes, I feel like, take monoclonal antibodies for granted just because they've been around for a while, but they're pretty cool tools. Basically, rituximab and obinutuzumab, when you're making a monoclonal antibody, these days we sometimes call these naked monoclonal antibodies. And that's because, we've taken steps with different, trials and different diseases to sort of modify them even more. But essentially what rituximab or obinutuzumab is it's an antibody that's built to attach to CD20, which is on the surface of B cells, both normal B cells and malignant lymphoma type B cells. Basically we want to trigger an immune response that's going to help your body go after those B cells. And that works to a degree alone, but it works, more substantially when we partner it with other things that also stress those B cells. So rituximab has some unique properties in WM. Probably the most common, unique thing is the IgM flare that we see when we start it. So if we start rituximab, either alone or in combination, we should expect that within the first month or so, the IgM is going to go up by about 25%. So it's going to go up before it goes down. For whatever reason, it's also true. One of the main side effects that people have with rituximab infusions, and I'm sure some people here have had this experience, is reactions during the infusion, is infusion-related reactions. So we start the infusion, we give you your pre-medications, your Tylenol and Benadryl and steroids, and still chills, fevers, sometimes rash, can develop, sometimes even breathing problems or blood pressure changes. And that's more common in WM than it is in other diseases. So for some reason, patients with WM are more susceptible to CD20 monoclonal antibody reactions. So we have our share of folks with WM who just, you try rituximab and it is touch and go every time we do it. Or you try Obina because the rituximab was touch and go, and that's touch and go as well. Sometimes in the past we've used ofatumumab. That's a tougher monoclonal for us to get access to. It's kind of off market these days, but that is something that is a unique characteristic of CD20 monoclonals in WM, is that they're a little tougher to give, even over time. And then we know these are immune suppressive. Unfortunately, like everything we're going to talk about, I think about it just kind of fundamentally. When we have WM, it's a disease that comes from your immune system. So essentially, anytime we're trying to knock that WM down, whether that's indefinitely or for a fixed period of time, we're going to knock down your normal immune system too. So all these things are immune suppressive to some degree. But the degree of immune suppression with rituximab or other CD20 monoclonals really depends on how big the combination is. So if they're on their own, they're pretty modest. When you start putting them together with more chemo partners, they become more severely immune suppressive. And the combination we use most often these days is BR, bendamustine and rituximab. We use this in WM. We use it in other indolent lymphomas. So some of the data from this comes from trials that was not just WM. It was WM plus follicular lymphoma, mantle cell or marginal zone lymphomas. So some of our data has sort of that kind of put to bed other combinations. It used to be there, before my era, people used to give R-CHOP for WM, and this, head-to-head stuff sort of showed that PR is probably better across indolent lymphomas. And then we've gotten some WM broader, more specific data. And, this is a really effective combination. So if anybody has not had treatment and they're looking at their first treatment option and they walk into the doctor's office, undoubtedly one of the discussions is going to be around BR and if that's the right fit. Because the response rates are really high, greater than 90% in some trials. And we measure responses based on, reduction in IgM. Sometimes if it's low enough, we do a bone marrow biopsy to kind of confirm. It's tough because in WM, building out studies that sort of paint great pictures for averages in terms of duration of remission can be tricky. But something in a 7 to 8 year range for median duration of remission with BR is kind of average. And averages are just that, that 50%. So 50% is going to come back sooner than that. 50% it might last even longer than that. So I tend to think, we get a little too reductive, unfortunately, sometimes with our expectations. Other partners we sometimes use, like I mentioned, cyclophosphamide. That's probably our second choice if we're thinking of a chemo partner for the rituximab. It works sort of similarly. They're both alkylating chemos. It's a little less robust in terms of the reductions you get with the bendamustine. So response rates with it are similar, but you get less deep response and they're a little bit less durable when we do like cyclophosphamide and dexamethasone. That's sort of similar to the proteasome inhibitors, which are tools that we don't use it often first line. We may use them a little bit more second line, or if we have the right patient who's not going to be, who's hesitant around bendamustine, rituximab, or BTK inhibitors, then we might think of a proteasome inhibitor-based combination. I truthfully tend to use a little bit more carfilzomib-based combinations. It's a little more potent in terms of reducing the WM. So if you're eating in the second or third line setting and you really want some juice for what you're doing, using a more potent proteasome inhibitor may help with that. But these are also relatively, ideally fixed interval treatments. You're doing 6 months and then, transitioning to observation. Our other big category that we use most often, and if we're sitting down for somebody to try to sign on to the first treatment, is BTK inhibitors. You can't give a BTK inhibitor talk without these like fancy, cool, like fingery graphs. So those are basically, BTK inhibitors, what they are is they're called, they're tyrosine kinase inhibitors. So that's one of our go-to ways for oral targeted therapy. So these are pills. And they were groundbreaking. The first one that was approved, but they were the first approved medicine specifically for WM, and that came first with ibrutinib in 2015, and then with zanubrutinib in 2021. And then there are some other approved BTK inhibitors for other lymphomas like acalabrutinib, and like I said, I'll talk about pirtobrutinib, and I guess I'll spell it also, but pirtobrutinib, which is, but basically, these differences are that they're all inhibiting. So there's a signaling cascade that turns on WM cells, and the BTK inhibitors try to turn that off. But they all have slightly different binding. And so they all end up with, because they're slightly different molecules, they have slightly different effectiveness and side effect profiles. And that does shape which ones we use. So that's where these little different red dots are, is because they're blocking both BTK and maybe some other kinases. So that's what these maps that you might sort of see if you're, they just also look nice. So people put them in their slides. But BTK inhibitors, are once or twice a day, depending on your agent. And the way I think of them is a little different than chemo. Chemo is trying to kill your cells. It's going to, stress these cells in a way that helps to make them die relatively quickly. So when if we need a treatment that's going to work fastest, it's often like BR. BR is going to reduce your IgM, reduce the number of plasma cells in your bone marrow, maybe by 50% over a month or two. And if we need to do that, if we need to get things under control ASAP, chemoimmunotherapy may be our best path for that. Whereas the BTK inhibitors kind of, they turn off the cells. That's kind of how I think about it. You have this thing that's turned on to activate your WM cells, and we're going to flip the switch right below it to try to turn it off. And you do get sort of cells dying off, but they just take longer. So that's why, as Kate mentioned, when we stop a BTK inhibitor, we often see IgM starting to go back up relatively quickly because we haven't eliminated the population. We've just turned it off. Initially it was evaluated, ibrutinib was initially evaluated with rituximab. We don't really give it all that often with CD20 monoclonal antibodies just because we don't know what that adds to it. Some people were asking about frequency of certain complications and stuff. And the best way for us to sort of look at that and to compare it across our BTK inhibitors is these are the drugs we've had the biggest trials with, so our biggest bodies of data come from ibrutinib and now zanubrutinib trials. And we did get a good update. This was not last year, but the year before on the Aspen trial. So this was comparing zanubrutinib to ibrutinib, okay? Because these days when we start a BTK inhibitor, more often than not, we start a second generation. So if you were started on a BTK inhibitor, 7 or 8 years ago, you'd been started on ibrutinib. That's the one we had. Nowadays, you start more often with the zanubrutinib. Some patients may start a calibrutinib depending on their doctor's situation. But essentially, we think of them as having similar response rates. So ibrutinib total response rate, that's at least a 25% reduction in your IgM. So at least 25% is a some amount of response. 95% zanubrutinib, 94% ibrutinib, very similar. Major response rate, that's greater than 50% reduction in your IgM. Again, very similar, 80, 81%. So high rates of very good, of major response. We usually start to see maybe a little bit of a difference in terms of the rate of even deeper responses, 90+% reduction in the IgM. That's about 36% with zanubrutinib versus 25% with ibrutinib. So we may get more VGPRs, we call them, so deeper responses over time with the more sort of directed zanubrutinib. In terms of progression-free survival, there is a little trend towards patients who get zanubrutinib having more durable remissions as well. Not what we call statistically significant yet. And then, in terms of side effects, this is probably where the bigger difference lies. Patients mostly respond to either one, and the durability of remissions is pretty similar. But we do see a lower rate of most of our most common side effects with zanubrutinib in comparison to ibrutinib. So somebody was asking about this. So this is, rates of atrial fibrillation. That's the heart arrhythmia that we worry about. Maybe it was our most complicated side effect that can come from these things. That's up to about 17 or 18% over time with ibrutinib versus about 4 or 5% with zanubrutinib. So that's like a 75% reduction in how often we see AFib, which is a pretty common issue. In terms of bleeding rates, Kate mentioned that, something like 30% reduction in bleeding rates with zanubrutinib compared to ibrutinib. And even lower infection rates, which is maybe surprising given how potent and effective it is. So, kind of across the board. One of the studies that, was presented recently that I think is kind of interesting, because lots of folks have trouble with ibrutinib or have had trouble with ibrutinib, and it flavors their perspective about BTK inhibitors in general. And most of us who treat this a lot have said, well, you have a portion of patients who've come off of the ibrutinib because of side effects, and we've tried moving towards zanubrutinib and it's gone well. But do we have any data that sort of evaluates that more formally? And the group out of Fred Hutch in Seattle did that. It's not a huge number of patients, but basically this was different diseases, but part of them were WM patients who were intolerant or had to stop ibrutinib or acalabrutinib, the BTK we use least often in WM. And then tried zanubrutinib, And so basically of those folks who stopped another BTK because of side effects, like 2/3 of those side effects did not happen again when they tried zanubrutinib. So a lot of patients had discretely, measurably better tolerance of zanubrutinib, even if they had to stop ibrutinib. So this is what I sort of cite when I have patients who are reluctant around trying zanubrutinib because ibrutinib was a tough go. And then the patients who did have recurrence, they were often less severe. So that would be something like you have some GI upset, but not as problematic, high grade. And a lot of patients, and those patients almost all responded. So they also had good responses to zanubrutinib if they didn't have to stop the other BTK inhibitor because of intolerance. That's different than stopping because it stops working. So this is not people who tried zanubrutinib after the ibrutinib didn't work or they worked for a period of time and then the WM came back. This is more people who stopped because they had side effects that made it so that it wasn't manageable. So, what's the right fit for me is often the question, what we're trying to pull apart when a patient's recently diagnosed with WM. And it's complicated. I'd sort of say of all the situations, in a lot of things in the clinic when patients come to see us, if I have a patient with newly diagnosed myeloma, we're almost always going on one path. We have a combination. We think that's our best in class. That's the path. Whereas with a new diagnosis of WM, it really is a shared decision, sort of us trying to give the best guidance, best information, because, the path towards BR versus the path on the BTK inhibitor is pretty different. And there are some people who say, oh, that's exactly the right one for me, or nope, that's the other one's the right one for me. So it's really about going through some of these things. Do you want something, is the priority that you want to do something that's fixed duration, BR's 4 to 6 months versus the BTK inhibitors indefinite? Or is your preference towards something that's chemo-free, where you don't have that sort of chemo side effect over the first 4 to 6 months? And, sort of trading off, sort of that needing to take a medicine indefinitely for that sort of a specific, exposure. So there are some differences, and there are maybe some situations, like I said, if you really need deep reduction of your WM right away, we may need to go towards chemoimmunotherapy just because that's going to shrink those lymph nodes or clear out your bone marrow or produce that IgM quickest. But I do think it's it's something we want to make sure we cut through all those pluses and minuses of each thing and try to be as transparent as we can be about what those pros and cons are. Are there comparisons between BTK inhibitors and chemoimmunotherapies head to head? Not really. Unfortunately, so when you're trying to get your new treatment approved, if you're going to get your ibrutinib approved, usually you take the path of least resistance, and historically the path of least resistance was like single agent rituximab. So when ibrutinib was approved, it was compared just to rituximab, not to BR or cyclophosphamide or rituximab, something that would have been a little bit more informative. Truthfully, I think a lot of folks were impressed by zanubrutinib taking the full Pepsi challenge and going head to head with ibrutinib when they went for their approval. Admittedly, they went for that approval thinking they were going to kick their butt from an efficacy standpoint, and they did beat it a little bit, but mostly they were safer to a degree that led to that approval being pretty straightforward. So how do we compare? The best we can usually do is kind of real world data. This is something that was kind of interesting from last year's ASH. This was the Whimsical registry, which it's some folks out of Australia who helped run it, but it is supported by the IWMF, and this is basically patient-reported outcomes. So this was not centers giving their data. This was patients giving their data about what their treatment was and how they're doing over time and how they're, and what we call quality of life. So that's like their experience and how well they're feeling. And so basically this compared BR with a BTK inhibitor and showed similar durability of responses across these real-world patients. This was mostly ibrutinib. So most of these patients have been started on their BTK inhibitor before zanubrutinib or acalabrutinib might be available. In that setting, patients with so similar durability of responses across these patients. Quality of life was interestingly better in patients with the BTK over the first 12 months. That's when you're going to have most of your chemo side effects if you get BR, and then they kind of move out. So over time, it was more comparable. And again, that is also in the setting of ibrutinib more so than zanubrutinib. What about if BTKs are good and chemoimmunotherapy is good? What if we put them together? Is that even better? That's something we're trying to look at. We've been really we were working hard to open this Zebra trial. The Z is for zanubrutinib, the BR is for BR. So that's where the Zebra trial is, and we're going to be one of just 3 sites. This is most stuff in WM that is we call it investigator initiated. That basically means a trial that's been come up with by WM experts as opposed to just drug companies. A lot of that is driven out of Dana-Farber, and we're collaborators with the group from there. So we'll be just one of 3 sites here at CBCI that'll be enrolling patients to the Zebra trial, and we're hopeful that'll start this month. So we're finally on the homes. It has been an absolute labor of love for Dr. Mattis to try to get this open, and he's had to bend over all directions. So now we are going to be open. So basically the goal with this is to try to combine BR with zanubrutinib for, to try to get that extra efficacy from all these things together and for it to be fixed duration. So you're not doing zanubrutinib forever. You're doing it for 15 months as well as 4 months with the BR.
question. Yeah. So how do you do that? Do you do like chemo and the pills at the same time, or how
They're concurrent. Yeah. So they would, you'd be doing the chemo and the pills at the same time for those first months, and then you continue on just the zanubrutinib afterwards. And the goal with this, and so this is part of a WMNet. We're one of the WMNet sites, which is our main research collaboration for what, and this is our first, and hopefully we'll have others down the road where we'll be partnering with these other sites as part of this. Investigator led. This is where we try to get our heads together, say what do our patients really need? How can we move the needle forward as opposed to just what's already being developed. And we do actually have pretty good proof of concept for this. This is a Canadian study called the ROM trial, which was basically the same thing, BR, but with the acalabrutinib. And this was not just in WM, but it included WM patients. And, it basically seemed to drive a really high rate of those 90+% reductions at the WM. We don't have long-term follow-up. Deep responses are great, but what you mostly want with that is to increase the proportion of patients who are still in remission, 8, 10. So we're still waiting on that, but that would be the goal. And so we think we have proof of concept that this shows deeper responses than we've achieved in the past. And it's not the right fit for everybody. If you have somebody who comes in and they're not robust enough for us to throw the full fastball at them, it may not make sense. But if somebody is and they want to say, let's go for this, let's try to lock in a really, really good remission, this might be a great tool for us to try that. So now just to get back to stuff that is in development. So what's on the horizon? So those are the tools that are in our toolbox already. What's coming? So BCL2 inhibitors, and those are a mix. They're kind of in the clinic, but they're going to come even more. We're getting better data, better molecules. New BTK inhibitors, or BTK targeting. So that's both new BTK inhibitors as well as BTK degraders. And then, unfortunately, we're still working on trying to move some of our new immune therapies forward a little bit more. So BCL2 inhibitors, what's BCL2? BCL2 is something that has become a key target for us, not just in WM, but in a bunch of different blood cancers. So this is one of the things we're targeting most actively across different lymphomas and leukemias. Basically, BCL2 is how cells try to stay alive that shouldn't stay alive. BCL2 is part of preventing what's called apoptosis. And apoptosis is when a cell that is supposed to die dies appropriately. So basically, cancer cells, part how they live is by stopping that. They keep themselves alive even though they shouldn't be. And so basically by blocking BCL2, inhibiting it, we can make cells die the way that they should when they're not normal cells. So venetoclax is the main approved BCL2 inhibitor that's in use across different diseases. It's approved for AML, it's approved for CLL, and it's effective in WM. So, we've all treated patients. There may be some people here who've had venetoclax as part of their approach for their WM, because it is accessible. And so we know from Jorge Castillo's one of the main WM experts out of Dana-Farber, and he presented some data from his center and a couple other centers that showed like an 80+% overall response rate. That's at least a 25% reduction in WM. So we know it works. How does it compare to BTK inhibitors? They're different. Essentially it's a different modality. They are also often indefinite oral therapies. When we're using them the ways that we're currently using them, it's often because the WMs come back, and if it works, we're just going to continue that in an open-ended way. There are different side effects. The main thing that's kind of, shapes the experience is that we have to be careful with tumor lysis syndrome, which is basically when you take the pills at the full dose, they may kill too many lymphoma cells at the same time and sort of, release things that stress your body. So we have to do dose step-ups to get to our full dose. The hope might be that down the road, we come up with chemo-free combinations, that we can think about partnering BTK inhibitors with BCL2 inhibitors. That's been a very useful approach in diseases like CLL, where we can do bigger trials a little faster. But these may be really good options in the future for chemo-free combinations that are maybe not indefinite the way that BTK inhibitors currently are. So they're, like I mentioned, venetoclax is something we use now if we need to, but whenever we need one of these, we're always going to say, do we have a clinical trial that might be available and might make sense? And right now, the BCL2 inhibitor that we're doing most with that is sonrotoclax. So sonrotoclax is, it's another way to target. It's another BCL2 inhibitor like venetoclax, but it is one that's maybe kind of like zanubrutinib was a refined version of ibrutinib. The hope would be that we can come up with some BCL2 inhibitors that are refined versions of that venetoclax. And it's nice because sometimes when you have a new version, they need new diseases to evaluate it. And so that's sometimes where you get a little bit more emphasis on things like WM, where, because the venetoclax is what we call kind of a mature drug. We're not going to get an approval for that in WM. So this is the trial we have ongoing. It's, I don't know, it's got a long alphanumeric name, but basically it's an open, it's a phase 1, which basically means we're looking at initial signs of effectiveness and safety, and we're doing that in different dosing steps. So basically we're at now the 640 milligram dose level. And this is not just in WM. We have this open in multiple, it's something that we use to treat different lymphomas who need a trial option. But we do have some specific data in WM that looks really promising. In terms of side effects, these have a manageable side effect profile. They do cause some things like anemia, neutropenia, low blood counts are not unusual, some GI side effects. But in general, the side effect profile is shaping up to be pretty manageable. And the effectiveness profile is looking really good. The overall response rate across all these different dose levels, because sometimes the worry with these is that, the first couple, when you're doing dose step ups, the first doses you give may be 1/10 of what you give a few, 6 or 9 months later. But even at the lower doses, we were starting to see some responses. So I think we've had nice responses with this so far. And so far, some of them are looking relatively durable. So, this is including patients who had BTK inhibitors as their last treatments. So even in patients who had to, who just came off of a BTK inhibitor, we had an overall response rate of 67, 70%. And, we're seeing more about the durability. So every one of these things with like an arrow moving forward is a patient who's still on trial and still responding to their therapy. So the story is being told. That's how these trials are. When we present this preliminary data, it's because we're just getting the first glimpses of how things work, but so far looking promising. And we are looking at it in combination too. So this would be that, this is combining some sonrotoclax with zanubrutinib to look at patients who, different types of patients, but patients with WM who may benefit from combination therapy. So we're doing that too. Non-covalent BTK inhibitors. So I mentioned that this is different. Basically all of our approved BTK inhibitors for WM are covalent. Covalent basically means they bind in a certain way. They bind indefinitely. But basically the difference is that when we block BTK, if there are some ways we can block it that just work totally differently. So the non-covalent BTK inhibitors bind to a different spot on BTK. And so they may work well in patients who have progressed on other BTK inhibitors, patients who've had zanubrutinib or ibrutinib and they stopped working, or maybe patients who can tolerate them. And there is one approved non-covalent BTK inhibitor already in the clinic, pirtobrutinib, but it's not the one right now in trials at CBCI. We're working on nemtabrutinib. So, but it's another one. So the pirtobrutinib is the same sort of thing. The first one, when it gets approved, it may not spend the time and effort and money to be specifically evaluated in WM, whereas the other versions, the newer generations, they may pay that money to study it specifically in WM, knowing that they need their foothold, and a rarer disease may be that better foothold for them. So sometimes we have to work more with the second version. But the pirtobrutinib gives us really good proof of concept and maybe an off-label option for folks that works quite well. So basically, just the difference, some of the BTK inhibitors, sort of fine tune it and block it. This way, pirtobrutinib actually shifts the way it folds on itself. But the piece of it they worked in again, it had one of those cool, funny looking, tendrily things. So, so basically, that they block differently, and that leads to defined efficacy in patients who've had other BTK. This is from the BULA trial. This was again across all a bunch of different lymphomas, but included a chunk of WM patients, 80 WM patients, including 63 who had prior BTK inhibitors. So this was largely patients who had BTK inhibitors, and the responses were good. Including in patients who'd had prior BTK inhibitors. Overall response rate of 78%. And a major response rate, that's the greater than 50% reduction in your IgM, of, 50, 60+%. And, this is a waterfall plot. This, everybody who goes down on this is somebody who responds to treatment. So this is this is a really large proportion of patients, including those. These are the dark blue blue lines are people who stopped BTK inhibitors because they stopped working. Those are patients whose WM progressed through ibrutinib or zanubrutinib. So that's a lot of patients. That's a lot of dark blue lines that also responded to pirtobrutinib. So we have good proof of concept and, preliminary data that these non-covalent BTK inhibitors. Yeah.
For somebody who did not react well or had to go off a previous BTK inhibitor, would you automatically put them back on the pirtobrutinib as the next step, or?
It depends. I mean, my goal to be very frank, my first recommendation is probably going to be, let's see if we have a trial. I think trials give us access to novel therapies that, if we have a path, if we have a way to get, Pirto's there. If we need to try to get, sometimes insurance may be problematic. It's not approved, so that there's always a chance they say no. None of these are medicines that anybody can afford out of pocket. You'd have to be, that's like, you'd have to, it's, maybe in the Silicon Valley area, there's a handful of people who could, go out of pocket for this. For the most part, these are things we need to either get approved or get drug company access to. So Pirto is a bit of a, it's something we have to be able to go through that process. But, my first thought, if somebody progresses, if we're progressing on a BTK inhibitor, I'm going to say, let's look at our trial portfolio, because that's our job here. And part of what, truthfully, one of the really exciting things about me joining this group, last year was how robust our clinical trial program is. And just, if we want to onboard something that don't get a lot of pushback or anything, they say, let's do it. And so, having access to, different BTK and newer BTK inhibitors, BTK degraders, and BCL2 inhibitors. So my first thought would be, let's see what we got as a trial. But if we needed something, if I had a patient who was, we certainly deal with our share of patients, who are in Billings, Montana, or down in New Mexico, and they can't come up here for all that comes with the trial. That's where, we might say Pirto is your next step if that was a good approach for you. Okay. And again, whenever we do the side effect profile, it's a huge list. It's got a million things on it, but, what we're mostly looking at is how often, and any time that the main, sort of things that happen are happening at a 30%-ish rate. I kind of like that. So what about BTK degraders? This may be the area of greatest excitement right now. So we talk about BTK. I have like this sort of, So this shows, this is the cell surface. This is the surface of your B cell. Okay. And this is this receptor. This is what something binds to turn your B cell on. So B cells are not always active. You need to turn them on. A virus and stimulates a B cell because it's a provocation. Then you get this signaling through this pathway. This thing triggers that thing, triggers that thing. It's kind of cool. It's a cascading. And so this is where BTK lives. And this is where my MYD88 lives. So when MYD88 is mutated, it's turned on all the time. And that's 95% of patients with WM. That MYD88 is mutated and turned on. So if you block BTK right next to it, very rational, you can turn that off. But these other things can still get together. And maybe you find, maybe one of the ways people progress on BTK inhibitors is because this whole complex finds a way around it. Our cells are very, they're stubborn. They find ways around some of our pressures. So sometimes maybe you find a way around it by putting this whole complex together and still signaling. What about if we destroy this? If we can get rid of BTK, then you can't make this complex. So that's what a BTK degrader does. This is a cool class of drugs. I think they could be very impactful, not just with BTK, but with a bunch of other things where you need to break down a protein in a cell to sort of stop how the cancer is driven. But one of the most rational targets for them to begin with, so we may see a whole bunch of degraders of different things that work in different diseases. But one of the things that is a very rational first thing to target with a degrader is BTK. We know that turning it off works in some cancer, but we know it doesn't work forever for many patients. So we're looking at there are multiple BTK degraders in development. The one that we're most active with in the clinic is, it's by a company called Nurix that's been sort of at the front edge of this stuff. So maybe this is a way to overcome resistance to people who progressed on BTK inhibitors because of a mutation. So mutations can be one way that people stop responding. Basically, the area where the the inhibitor is going to bind changes, so it doesn't bind there anymore, can't bind there anymore. Maybe some people develop resistance because that complex can still come together. So maybe by degrading BTK, you can stop that complex. We call it scaffolding function. It's kind of a fancy term for just like that thing that we saw with the protein sticking together and creating a signaling cascade. So maybe we can both block BTK and disrupt that scaffolding function to more effectively eliminate this signaling pathway. And again, early-ish days, but so far so good. In terms of patients being treated with this, this is just patients. This is across the whole, study. This is the trial we're part of. This NX-5948 molecule. It's being, for now, mostly evaluated in this study that's looking at all different types of lymphomas, but has a group of WM patients. The side effects look really manageable. And, the effectiveness is looking good. So this is just WM patients. There's only been 13 of them that have been described so far. We have more than that treated, but that's what's out there now for us to share. And, essentially this is what happens. Across all these different doses, you give some treatments and all of a sudden the BTK is just gone. So this is BTK levels and sort of very robust. This is like is our drug working the way we want it to? And the way we want it to is by getting rid of that BTK. So really robust reductions in the BTK levels. And these are the responses. So basically these were all patients who had BTK inhibitors. And some of them have even had that pirtobrutinib or the non-covalent BTK inhibitors. Essentially, the triangle is progression. So some patients do have progression, but a lot of patients had stable ongoing remissions. That arrows again means that you're still in remission over time. So the story that's being told, but so far looking really exciting. And these are a couple of cases that they sort of showed. These are patients who've had, this is a patient with 4 prior lines of therapy, including a stem cell transplant and a prior BTK inhibitor. And this is the reduction in IgM over a year on the BTK degrader. So, pretty cool. This is another patient with a similar sort of thing. And this is a patient who recently just relapsed before this on zanubrutinib, but they'd also gotten stem cell transplant. They'd gotten, kind of kitchen sink of what our options might have been in different scenarios. And so this is the IgM trending folks. So lots of folks with, as with kind of BTK inhibitors, it may take time. We don't necessarily see the IgM go down abruptly in everybody, but, over time we may get that gradual deepening that is really common with our BTK inhibitors. Last thing before we jump into some Q&A is just what people are often wondering, what about bispecifics and CAR Ts? These are immune therapies that have been relatively transformative in lymphomas outside of WM. So in our more aggressive lymphomas, CAR Ts are a really important thing. Basically, a CAR T is where we take somebody's T cells out, we genetically modify them, we expand them, we give some people chemo to clear a path, and then put the T cells back in and let them go after the lymphoma cells. Right now our data on that in WM is fairly limited. I think because we have so many targeted approaches, those have become the things that are a little bit more robustly being evaluated. We are working on some trials through the WMNet that I mentioned before that are geared around particularly bispecific T cell, bispecific T cell engagers. So a bispecific is a little different. So bispecific is kind of like rituximab. Rituximab is an antibody. But with rituximab, both of the sides have been attached to the same thing, which is CD20. With a bispecific T engager, one side attaches to something like CD19 or CD20 on the lymphoma cell. The other side binds to a T cell and brings it right next to it. So instead of having to take your T cells out, manipulate them, and put it back in, we can just put an antibody in that just does that for us. It puts them right next to each other. So that my question would be that may, those have been particularly promising in indolent lymphomas, things like follicular lymphoma. So those might be the easier thing for us to have a path forward for in WM as we're looking to expand our immunotherapy toolbox. So that's my talk.